Good morning, everyone. I thought I would talk about a topic which is quite common both in first opinion practice, as well as I think it's one of the most common reasons we get dogs referred in medicine, and that is if they have chronic diarrhea. So imagine you're consulting, you've got a busy day, you've got a full list of consults. You are getting close to your lunch break, you can feel it, so you might actually finally have time to write some notes, but then your next consult pops up. And the consult says, still has diarrhea, carer, not happy. And I think I come from a country where not many people have carpet in their home. And I think moving to a country where most people have carpet in their homes, the frustration is even greater. So your patient is Misha, who's a 2-year-old male-neutered border collie. Picture this Misha in better times enjoying his Christmas lunch. Misha has had diarrhea for 4 weeks, and he's got some tenesmus and hematochezia with that. He has already been for a consult about a week ago, where your colleague advised to try some Procolin and feed him some chicken and rice, but that hasn't really worked. And Misha is up to date with worming because they collect that from your practice. First impression. Picture yourself consulting that day, you see this consult pop up. What thoughts are going through your mind? Any feelings, emotions? So I think some of you got it already, but spoiler alert, your likely diagnosis, simply because it is very common, is that this dog has a chronic inflammatory enteropathy. And there's recently been a new consensus statement published about that, if you want to have a look, where it's defined as having chronic, which is more than 3 weeks, or recurrent GI signs. So also think of it with those dogs that you tend to see once every 2 to 3 months because they have an acute tummy upset. They probably will have a chronic inflammatory enteropathy as well. And they have sort of varying degrees of mucosal inflammation. And one thing that's important to bear in mind is that it's an umbrella term, so it encompasses quite a wide spectrum of disorders, from our more standard ones to our special cases, our PLEs, or our granulomatous colitis. And you might remember that we can classify these according to their response to various interventions. So we have our diet or food responsive, our steroid or immunosuppressant responsive, and finally our SAD category, our non-responders. You might remember there being a 4th category, antibiotic responsive, but that has become more and more controversial. Antibiotics might improve their signs temporarily, but it doesn't sort of fix the issue and you get stuck in this vicious cycle of more and more antibiotics. But we have skipped quite a few steps here, of course. So how do we get to that diagnosis? And as a concept, chronic enteropathy is a diagnosis of exclusion. So your first question that you should bear in mind throughout this process is, am I missing something? Am I missing another diagnosis that could cause these clinical signs? The second is, as I said before, it's a wide spectrum of disease of varying severity. So the second question you should keep in mind is, how worried am I about this particular patient? And I like to break these down into 3 steps of investigation. The first step being our non-invasive tests, so our blood test, fecal test, and urinalysis. The second step, slightly more invasive, would be to do some imaging, as it usually requires some sedation or general anesthesia. The third step, we'll leave that as a question for now, and we'll get back to that. If you were concerned that AI is coming for your job, I asked AI to make these diagrams of a dog getting a blood sample taken. If you look closely, it doesn't quite know how to do it. And the ultrasound, I think it's, if you look very closely, it's a human baby on the screen. So I think we're good. Lovely. So back to Misha, you've got him in front of you. What is our first step? Yeah, so our first step is to do a basic assessment, of course. We shouldn't skip that step. So to take our history and perform our physical examination. And again, keep those 2 questions in mind. So the first one, am I missing something? Of course, if you palpate Misha's abdomen and he's got a mass, you should focus on that. The second one, how worried should I be? There are some things to bear in mind here. First one being, of course, how severe his clinical signs are. It's also important to try and remember to body condition and muscle condition score these patients. And finally, keep an eye out for any signs of peripheral edema or ascites. I'm not suggesting that you POCUS every dog with chronic diarrhea that comes into your consult room. But if you do think there's a fluid fill or if the abdomen looks quite distended, that is something to bear in mind, because all of these things are prognostic factors. They're all negative prognostic factors. If you find that a bit hard to ascertain like how worried you should be about a particular case, there is a tool to help you with that, which was developed in a research setting, and it was developed quite some time ago, which is why it uses the term IBD, which we now feel is more of a human term, so we're sort of moving away from using it. But it's the CPD score. Essentially, it scores 6 points that you can get from your history and from weighing the dog and seeing if he's lost weight. And you score it on a scale from 0 to 3. You add the scores up per category and then you get your total score, where a higher score means the disease is more severe. Again, you don't necessarily need to do this every time, but for those cases where you sort of keep umming and ahhing about them, you're not quite sure, it can be helpful. So let's go back to Misha. You start examining him. You find that he is in a good body condition and his physical exam is unremarkable. In terms of his clinical signs, he's been a bit quieter. He's eating about 80% of his portions, so not terrible. His feces is soft and not formed, and he does have increased frequency of defecation. If you were to do the CPD score, you would get to about a 6, which means he has moderate disease activity. All right, now I need some inputs. Misha's carer is concerned, so she would like you to investigate matters further. What blood test would we suggest doing for Misha? In terms of our blood test, what are we looking for? Again, keep those 2 questions in mind. Am I missing something? If Misha has renal failure or severe hepatic disease, you should probably focus on that. And the second question, how worried am I? There are certain things to look out for that are negative prognostic indicators, so they might mean that Misha is less likely to do well. These being having a low albumin, and the more severe it is, the more concerned you should be. Hypocobalamin or low vitamin B12, it is fairly common, depending on what study you read, between 20 to 60%. It doesn't mean that it's going to be all terrible, but it does mean that there is more significant disease there. If you have a PLE, increased BUN, increased urea, has been shown to be a negative prognostic indicator. And finally, it's worth having a look at your hematology as well. If you do find that there is anemia, especially non-regenerative anemia, or an increased neutrophil to lymphocyte ratio, or thrombocytosis, those are all markers of inflammation, so they mean that there is more significant sort of systemic inflammation. All right, now another poll. We're going to do some fecal tests. What would you commonly request out of these 3 options? I actually wouldn't. They're not as useful as we think they are. So generally, I would only perform a fecal culture in a very sick patient, so a patient that is septic, SIRSI. And that's because, again, they're not as helpful as we think they are. This is a very fun study, this diagram is from, where they had, I think about 17 dogs. They had dogs with diarrhea and healthy dogs. And they sent their fecal samples, so the exact same samples, to 3 different labs. And very briefly, they got 3 very different results. And also the results were not that different between the dogs with diarrhea and the dogs that are healthy. And essentially, even if you culture Salmonella or Campylobacter, treatment usually isn't indicated. You often will not clear them of the bacteria, and then again you get stuck in this sort of loop of prescribing antibiotics, retesting, still has Salmonella, more antibiotics, and you're not really sort of achieving your goal of actually solving the diarrhea. So let's go back to Misha. His heme and chem are unremarkable. Your B12 is sort of towards the lower end of normal. His folate and TLI are unremarkable. Your basal cortisol excludes hypoadrenocorticism, so you don't need to stim him. and his fecal is negative. Before we move on to the next thing, is there anything that we would suggest for Misha? Does anyone want to make a suggestion? That is the next step. So with this B12, as it's towards the lower end of normal, you should already start supplementing it. But exactly. Misha's carer is pleased that his bloods don't look too bad, but is still concerned. So she would like you to have a look and see what's going on. Now let's say you have quite a nice practice. You have both an ultrasound scanner and a CT scanner. Which imaging modality would you use? Which one do you think is best to look at the GI tract?
Very controversial.
Very good. Well. Very good. No, I'm pleased to see that. Yes, so an ultrasound is a lot better for looking at the wall thickness and the wall layering. CT scan really isn't that helpful. We do sometimes do CT scans in very large dogs because, of course, you'll find that your ultrasound is limited in terms of how deep the sound waves penetrate. So to get sort of an overview of the abdomen and make sure you're not missing something else, we in referral in larger dogs tend to do a CT followed by a focal GI tract ultrasound. But in terms of the GI tract itself, ultrasound is actually far superior. In terms of what we would see, in these cases that can vary. If you look at the image on the left, you will see that there are some changes there. So you'll see that there is the fluid surrounding that intestinal loop, the anechoic fluid there. And if you look at the mucosa, which is the innermost dark layer of this intestinal loop, you'll see that there is some bright speckling, and for the people near the front, you might see that there's some little stripes as well, some striations, which the speckling can indicate that there is some mucosal inflammation. The striations are a bit suggestive of lymphangiectasia. This was a dog with quite a severe PLE. But more often than not, it will look more like the image on the right, which actually looks normal. That doesn't mean that there is not inflammation on a microscopic level. So if you've done an ultrasound and it all looks normal, don't feel like you've not done a good job. That is actually very often the case. We more so do these ultrasounds to rule out that there is something else going on. All right, we've done Misha's ultrasound. It all looked unremarkable. What is our next step for him? So in Misha's case, our next step to advise would really be a diet trial, and that's for a couple of reasons. The first one being very simple. A large proportion of these cases with chronic diarrhea, where you've ruled out extraintestinal disease, will be diet responsive. Depends on which study you read. I think 90% seems a bit high, but 40%, I would say, based on my experience, definitely sounds about accurate. And then more specifically for Misha, there's a couple of other clues with him that mean that he is more likely to respond to diet. The first one being that he is a sort of moderate disease severity. And this is a nice study where they classified their chronic enteropathy cases according to how severe they were. And the bar on the left are the food responsive cases. And as you can see, that category is predominantly made up of animals with mild to moderate disease. Another reason being the nature of his diarrhea. You might remember that he had tenesmus and hematochezia, so he had large bowel diarrhea. And this is from that same study where the black are the patients that have predominantly large bowel diarrhea, and you can see again that the food responsive category, they are sort of overrepresented there. And then finally, another reason is his imaging findings, your ultrasound findings, which were unremarkable. This is a nice recent study where they looked at 115 dogs with chronic diarrhea. And they had excluded cases where you would be suspicious of neoplasia. So dogs with an obvious mass, loss of layering, or marked lymphadenopathy were excluded. And they did an upper GI endoscopy in all these cases. And essentially they looked at, if you were not suspicious of neoplasia based on your ultrasound, how often would you actually miss it? And they only found lymphoma in 3 out of 115 cases. So whilst it is not impossible, it is unlikely. And that brings me to, it's a bit of a sidestep, but I feel like quite a buzzword in recent years has been something called contextualized care, which I think vets in first opinion have been doing this for many years. And essentially it just means that you adapt your plan according to, patient factors, carer-specific factors, finances, etc. And I think that's important because if you read the new consensus statement on this condition, it suggests that you do blood, fecal and urinalysis in every dog with chronic diarrhea. And whilst that would be great, I don't think that's realistic. So if we wanted to make a sort of empirical plan, what we could suggest doing is we treat with fenbendazole for 5 days to cover for giardia. You could try some probiotics, or fiber can be nice, especially in large bowel diarrhea, and to just proceed with a diet trial. Of course, you can expand that plan with diagnostics as you see fit or as is possible. Getting to our diet trials, there's a lot of options these days. I think the one that we would recommend the most commonly are the hydrolyzed protein diets. So that's our Purina HAs, our ZDs, etc. That doesn't mean that they're the only option. Some dogs just will refuse to eat them. So things like novel protein can be nice. High fiber, sometimes in those large bowel diarrhea cases can work. With our PLEs, we often go for low fats. GI diets, whilst they can work, you should be aware that there is evidence that they're less likely to give long-term remission. The success rate for that is a lot lower. Home cooked can definitely work, but it's hard to get it nutritionally complete. So if that's going to be a long-term thing, I would suggest that you get your carer to consult with a boarded nutritionist. And I would suggest to not feed chicken, as it's just a very common allergen. So if we go back to Misha, as we've discussed, we're going to suggest a diet trial, but how are we going to communicate this? I think it's good to give people options because we all like to feel like we have a choice in life. But I also think it's important to not overwhelm people with options. So I would say, give a few different brands. Sometimes people have had a bad experience with Royal Canin and they just refuse to give it and they want to try a different brand. You could say that rationally that doesn't really make any sense, but whatever, I think it's good to give some options. I would always suggest to transition gradually, so advise carers to mix with the old diet over sort of 3 to 7 days towards the longer end if it's a particularly picky dog. And then they should feed it exclusively. And you need to make sure that that's very clear what that means. So I sometimes go as far as saying, the only thing going into your dog's mouth will be this food and water. No, no snacks, no chews, no table scraps, no nothing. And then finally, it's important to make sure that there is follow-up and to make sure that the carer feels supported. So I would suggest to book these cases in for a follow-up appointment after 2 to 3 weeks on the new diet, because that's the length of time that it tends to take to see the first improvements. So if there's no improvement at that point, you don't need to, put them through it for longer, then you can just switch to a different one. And also it's a good point to see if the patient's body condition, muscle condition, and clinical signs have improved. Now, it did pop up when we talked about the next step before. What about endoscopy, right? I'm a medicine resident, surely I want to do an endoscopy. And I mean, they're really cool, they're really fun, that first and foremost. But they are more invasive. Yes, it's not a surgery, but they can cause some temporary discomfort, worsening of clinical signs, as well as they increase the cost of these cases quite significantly. And it's important to bear in mind that the main purpose of an endoscopy with biopsies is to see if there is neoplasia or inflammation. It doesn't tell you, if you find inflammation, what that inflammation will respond to. So more often than not, if dogs have not had a couple of adequate diet trials yet, that is still our advice if we find inflammation. So when do we scope? First and foremost, Endoscopy never replaces any of the previous steps, so we would never skip those steps. Generally, we would suggest doing an endoscopy if dogs have failed 2 to 3 diet trials and well-performed, tried it for long enough diet trials, or cases that are too sick, that are too severely affected to wait 2 to 3 weeks. In particular, PLEs we are more worried about. Why that is, we'll get to that in a minute. So especially the PLEs that have the single-digit albumin or that are just very, very effused, very edematous, I would be a bit more proactive. And of course, finally, if you do have an inkling that there could be neoplasia, so if there is abdominal lymphadenopathy, if there's loss of layering, or of course if you see mass lesions. You might also be wondering, what about surgical biopsies? I have to say that we rarely send our patients to surgery for surgical biopsies. Cases where we do it are the ones that have very marked focal changes or eccentric lesions in an area that you can't access with a scope. Generally, with an upper scope, you can sort of get into the duodenum. With a lower scope, it's the colon and ileum, so the whole jejunum is, an uncharted territory. I would say that if there is very sort of mild changes on your ultrasound, even if they are just in the jejunum, we often find that on histopathology, so on a microscopic level, they're actually more diffusely present, so an endoscopy is still adequate. And of course, surgical biopsies have the risk of dehiscence, which we do need to take into account. As I said before, we'll sort of dive into our PLEs briefly, because it's one of the things that make us more worried and more likely to pursue with endoscopy quicker. There's 3 large mechanisms of causing a PLE. The first being inflammation, the second being lymphangiectasia, or dysfunction of the small lymph vessels in the walls of the intestines, and the third being lymphoma, which we'll leave lymphoma for the oncologist. And it does depend on what you find on your biopsies, how you manage these. If they are predominantly inflammatory, I would suggest trying a hydrolyzed diet, and often steroids can help there, of course. If it is more lymphangiectasia, these often do better with an ultra-low-fat diet. Steroids are less likely to be helpful. That doesn't mean that we never try them, especially if they're not responding to diet as we'd hoped. If you're not sure, so you have your biopsies back and there's a bit of both, or if you don't have biopsies, there are now 2 diets which are both hydrolyzed and low fat, so they're a pretty safe bet, provided that your dog will eat them. And why do we worry about PLEs? It's because we know that the chance of them doing well is less than with our standard enteropathies. So again, it depends on which study you read, but there's about a 50-50 chance whether they are going to do well with treatment or not. If your patient is a pug, I would be a lot more worried, because we know from a study that their median survival time is a lot shorter compared to other breeds with PLEs, so about 100 days versus about 900 days. The second reason why we worry about PLEs is because we know that they often are in a hypercoagulable state, which means they are prone to forming clots, and that can result in acute deterioration or even death, which is why we put these patients on clopidogrel or other anticoagulants. If you are planning to get biopsies, I would take your biopsies first before you put your patient on an anti-clotting drug. So to summarize our approach to these cases into a 1, 2, 3, for your one patient, think of those 2 questions. Am I missing something, and how worried am I about this particular patient? And then take your 3 steps, your non-invasive tests, your blood, fecal and urinalysis, your abdominal ultrasound, and then finally either your diet trial for the majority of cases or proceeding with endoscopy if it is one of those cases where we are a bit more concerned.